So thanks Shiv and Jeff for inviting me, and Holly and Drew for introducing us. Let's see, it should say final, this one. Okay. Do you have a pointer? Is there a pointer? Somebody have a pointer? Where? Do you check your pockets, Mike? Okay. Nobody has a green pointer, do they? No? Okay, just checking. So I was asked to talk about cardiorespiratory control or interactions in circulatory control and therapeutic implications. And really, the quintessential example of cardiorespiratory interactions is sleep apnea. And I'm going to focus primarily on that, although the field is very broad and there's much that I'm leaving out in terms of what I'll talk about today. Obstructive sleep apnea, you know what that is. Ron gave a very nice introduction to it. Essentially, it's the apnea that occurs because of collapse of the upper airway during inspiration. It's an active kind of apnea. People are struggling to breathe. Contrast that with central sleep apnea, which is a very quiet kind of apnea. It's the kind of apnea you get with heart failure. You actually get it when you go to Everest or when you go skiing. You'll find that you or your spouse, your kids, will actually develop central apnea during sleep. Now, obstructive apnea is actually a neurologic disease because when you look at what happens, you can take the most obese human being, lie him on his back, and if he's awake, he won't obstruct. It's only when he goes to sleep that he obstructs, because when you go to sleep, you lose postural muscle tone, particularly when you're in REM sleep. That's the way you stop yourself from acting out your dreams. When you lose that postural muscle tone, you also lose tone in your upper airway. So the normal airflow becomes interrupted, either with a hypopnea, which is partial airflow, or an apnea, which is complete airflow. And the reason why you'll notice that somebody with apnea is worse when they sleep on their backs is because of the effect of gravity on this hypotonic upper airway and tongue. Now, clearly the treatment is, although we use a physical splint to open up the airway during inspiration, clearly at the fundamental level, what we need is to overcome that hypotonicity of the upper airway that comes on during sleep or during dreaming. Now, when you think of cardiorespiratory interactions, I've shown you something where the breathing triggers changes in the cardiovascular system. I will show you that. But remember, it works the other way around. The heart can change the way we breathe. And patients know this. This is an example of a patient with heart failure. In the upright position, the supine position, there's increased venous return, increased cardiac filling pressures. Now, those cardiac filling pressures are very uncomfortable for patients. That's why patients with heart failure sleep on 3 or 4 pillows. But what we see, I think we have a slide hidden. Sorry. And I don't have the slide with me, I'm sorry. I think it's inadvertently hidden. But what happens is when you lie flat and you have heart failure, you increase your AHI. So if you take somebody, lie them flat in the cath lab, monitor the AHI while they sleep, as the filling pressures go up, the apnea index becomes greater. They get more central apnea. Give them nitroprusside, drop the wedge pressure, drop the cardiac filling pressures, and the apnea index actually decreases. And this is an example of how the supine position, increased cardiac filling, can in fact bring on central apnea. Now, sympathetic activation, Mike talked about that. Microneurography, you see here in a subject lying supine. The point of this video is to show you that it's very easy to obtain these measurements when subjects are asleep. In fact, we can get measurements of sympathetic activity in sleeping subjects for between 6 to 8 hours continuously. And what we see is this kind of difference. These are healthy obstructive apneics, no other disease except the fact that they were newly diagnosed with sleep apnea the day before. They don't have hypertension, they don't have heart failure. These are healthy, normal subjects, just as obese as the obstructive apneics on the right. Now, as you saw from the earlier presentation, the number of spikes and the height of the spike, in a sense, tells you how much norepi is being deposited at the neurovascular junction. So the greater the number of spikes, the greater the height, the more your fundamental sympathetic central outflow is. Now these people are apneic, but they're breathing normally. They have a diagnosis of OSA, but they're oxygenating, they're very happy, they're very comfortable. The problem is when they go to sleep. Now what happens when an apneic sleeps? Before we understand that, we have to see what happens to a healthy, normal subject during normal, non-apneic sleep. And what sleep does is essentially change the structure of the sympathetic blood pressure control in the sense that as you get deepening stages of non-REM sleep, sympathetic activity falls and blood pressure and heart rate also fall. Now when you're in REM sleep, REM is rapid eye movement, is a time that you're most likely to be dreaming. When you're in REM, you find that you have very high levels of activity and intermittent swings in both blood pressure and heart rate. Now this is a very structured, normal response to sleep, to changes in brain state. When apneics go to sleep, the whole situation is completely different, defined by the cardiorespiratory interaction, because when take an obstructive apneic, you obstruct, you get hypoxemia, that stimulates peripheral chemoreceptor. And again, this is a very simplistic, for those physiologists cringing in the audience, this is actually a very simplified description of what happens to chemoreceptors. But when you get hypoxemic, the peripheral chemos are stimulated, relays in the NTS gives you two things, hyperventilation and sympathetic activation. Hypercapnia, remember when they're not breathing, they also retain CO2. So their CO2 levels go up, and that stimulates central chemoreceptors in the brainstem doing the same thing. Now when you apneic, you're not breathing. The thoracic afferents actually have an inhibitory effect on the sympathetic nervous system. So when you're obstructed and apneic, you're hypoxemic, you're hypercapnic, and you don't have your thoracic afferent input so that you have excessive sympathetic activity. And this is what you see in people with obstructive sleep apnea. An awake, healthy person only diagnoses sleep apnea, intra-arterial blood pressure 130/60. He goes to sleep, he's in REM sleep, he's dreaming, he gets intermittent obstructions. You see the increase in sympathetic drive with each apneic event, chemoreflex activation, and you see at the end of apnea with breathing resumption, the cutting off of sympathetic activity. There, and there. And look at the blood pressure rise, vasoconstriction, 240/130, intra-arterial. So this is real blood pressure going from 130/60 when he was wide awake. You treat him with CPAP, and you find that sympathetic activity is better and blood pressure is much improved. But there's something I want you to see here, and that is that while sympathetic activity is going up, look at the heart rate. You see a progressive bradycardia. And that's a dichotomy in terms of how we see the fight or flight response. Sorry, I had a bit too much wine in San Diego last night, and so it was long-acting red. And so I have a very so what you see is the fact that the sympathetic drive is accompanied by a parasympathetic drive, slowing heart rate. And that happens in only two physiologic occasions. One is the response to apnea. Now what happens if we take CPAP away? You take CPAP away there, you get an obstructive apnea recurring, and you see high levels of sympathetic activity, vasoconstriction, blood pressure goes up, and again you see this slowing of heart rate. And that's what I'm going to talk about in this next section. The bradycardia that accompanies apnea or the diving response. Now I have a quick question for the audience, and that is, if you take a healthy human and submerge the person in ice cold water, how long do you think that person can last before they become irretrievable in terms of brain and heart function? Anybody go for 3 minutes? 10? 15? 15? That 50 is a sensible answer, actually. 20? Ah, very good question. What age? 3 years old. Forever. Okay, we don't have forever. So let's say 30. We don't have forever, do we? So let's say 30 minutes. So Drew Armour's answer is 30 minutes. So this is a patient from Austria. Anybody from Austria here? No? All right. That's true. Yeah. So this is a 3-year-old girl who was with her parents, wandered off, fell through the ice, and they couldn't find her. They knew she was in the pond, they couldn't find where she was, and called for help, and it took 30 minutes before they found her. This was a small Austrian town near a ski resort. She underwent CPR, pupils were fixed and dilated when they found her, and this was after 30 minutes underwater. She was put on cardiopulmonary bypass support for circulatory and respiratory warming, and then because her lungs were full of dirty pond water, they had to put her on ECMO, which is an extracorporeal membrane oxygenator, where you don't have to oxygenate yourself through your lungs. And she was in a coma for a week. And after 2 weeks in hospital, she was discharged and came back in 2 years physically and psychologically normal. Now the question is, how is this possible? It is a remarkable thing that someone can be underwater for 30 minutes and survive completely intact. And that's the diving reflex. And again, maybe oversimplified for the purists here, but what it is hypoxemia activating through the NTS, not just the sympathetic nervous system causing vasoconstriction, but the vagus causing bradycardia. And both of these are inhibited by hyperventilation. Now this kind of response, this diving response, this ability to not breathe and remain intact for prolonged periods is used all the time by diving mammals, sea lions, dolphins, whales. And what they do is these sea lions are breathing atmospheric air. They go underwater for prolonged periods to feed, to play, to hunt, and the diving reflex senses the sea lion is not breathing. And it says, look, this animal is going to die unless we preserve the brain and we preserve the heart. And how do we do that? Well, let's take this finite reservoir of oxygen in the body and let's vasoconstrict everything except the brain and the heart. So all the oxygen available goes to the brain and goes to the heart. And that's why you've got that peripheral vasoconstriction that I showed you during apnea. And then it also reasons, it says, well, look, the heart is just pumping blood to the brain, so let's pump at 30 beats per minute. What does this do? It decreases cardiac oxygen consumption, and it increases diastole. And diastole is when the heart muscle perfuses. So all of the oxygen is rerouted to serve two purposes. One is to go to the brain, and two is to perfuse the heart during diastole, which is why, this is, by the way, is a healthy young ski instructor, wide awake, holds his breath, and you see the vasoconstriction to the peripheral blood vessels, and you see the vagal activation of the heart. There's a P wave, no QRS, complete heart block, and this is classically seen in many patients with severe sleep apnea. The more severe the sleep apnea, the more severe the hypoxemia, the more likely you are to see a bradyarrhythmia. Here's a sleep apneic patient with obstructive apnea, thorax moving, abdomen moving, no airflow, so you know it's obstructive, asystole of about 9 seconds, and this is a close-up to show you that he's got sinus, you see his P wave, P wave, P wave, sinus rate slow, so he's got sinus bradycardia, and he's got complete AV block because there's no QRS. Powerful vagal drive. So this is an evolutionary reflex that we may or may not have inherited from sea diving mammals, which is preserved to varying extents, particularly in young kids, but also in about 10% of the apneic patients. The treatment is not a pacemaker because these people paradoxically have very, very healthy conduction systems. The treatment is to treat the apnea. Now, what relevance has this got to patients? Well, in patients with heart failure, you know, we think that they die from VF and VT, but in this study from Liu and Stevenson, when they had monitoring of the EKG in heart failure patients who died, what they found was that more than half of the patients had a bradyarrhythmia, either sinus bradycardia or AV block. And the thinking, and we haven't shown this, I don't think anyone's shown it yet, is maybe these heart failure patients have undiagnosed sleep apnea, develop bradyarrhythmias, which the failing heart is less able to recover from. So now let's talk about atrial fibrillation. Anybody except Shiv can identify this guy? William Taft. Okay, we'll talk about Taft more soon. So let's get back to cardiorespiratory interactions and think about what happens in sleep apnea. You're sitting there, you're breathing normally, you're generating a negative pressure in the chest, your lungs are inflating, you're not thinking about it. Apnics, they have a block. So they generate these hugely negative pressures in the chest, minus 40, minus 60, minus 80. If you assume a one-to-one transduction, there's a pressure in the left atrium, the thin wall left atrium of 10. You've got the left atrium in a vacuum, so it's going to expand. Your ex-governor was in a movie, a Total Recall, right? Anyone see that? And he's out in space in Mars, and there's no atmosphere, and there's a vacuum, his face expands. Well, that happens to the atria, in a sense, when it's in an apneic chest. And when you look at the atria in people with newly diagnosed sleep apnea compared to similarly obese people without sleep apnea, the apneics have bigger atria. There's something about having sleep apnea that makes the left atrium big. Now, you've got sleep apnea, you've got hypoxemia, which I showed you, sympathetic and vagal activation, these blood pressure surges, transmural pressure gradients, systemic inflammation. All of these, which are classic of sleep apnea, are also things that cause atrial fibrillation. And what's the evidence that sleep apnea can cause AFib? Here's another case report of a patient seen by my colleague Sean Caples. And she was a 54-year-old lady, came in for carpal tunnel surgery, local anesthetic, not a problem. Everything was going fine, except during the surgery, she was sedated, she developed AFib. Now, because we're very sensitive to AFib and possibly having sleep apnea, she was sent in for a sleep study, and she really had no real risk factors apart from the fact that her BMI was 48 and her left atrial volume index was big, it's 31. And what we found on sleep study, this is a sleep study, we did a split night, half the night to diagnose, the other half to treat. This is the sleep stage description, this is oxygenation, and this is heart rate. And what you see is, in the first half, the diagnostic study, she has desaturations, and they're fairly severe, so she has significant sleep apnea. She also is in AFib because you can see the heart rate is all over the place. And then we put her on CPAP there, and her oxygenation corrected, which we expected, but lo and behold, her heart rate, her atrial fib converted to sinus rhythm. Now, this is obviously just a one-off case and doesn't really prove anything, but when we look at sleep apneic patients in the long term, those with sleep apnea tend to develop AFib at a higher rate than those who don't have sleep apnea. In fact, this is actually a dose-response effect. The more severe your sleep apnea, the more likely you are to have AFib. Now, for Shiv and his colleagues here who cardiovert these AFib patients, you want to know, well, of the patients coming to cardioversion, how many have sleep apnea? Turns out about 50% in a Midwestern population. I'm not sure about California or the West Coast, but in the Midwest, 50% of the patients coming to our cardioversion unit have significant sleep apnea. Why is this important? It's important because if you cardiovert these people, so for those of you who are not familiar with AFib is a problem where the atrium just quivers and clots form in the atria, and they can embolize and give you strokes. And it's actually a very, very expensive disease and a healthcare burden. So we treat it by shocking the heart and bring them back to sinus rhythm. Now, if you bring 100 patients in with AFib, you shock the heart to sinus rhythm, and you send them home. You don't ask them about sleep apnea. They don't talk about it. 40% will come back, or 50% will come back with a recurrence of atrial fibrillation within 1 year. If you treat their sleep, if you ask them, do you have sleep apnea, do a study, figure it out, treat them, 40% will come back in a year. If you know they have apnea and they don't want treatment or they don't tolerate treatment, you shock the heart, send them home, 80% will come back in a year with recurrence. So if you're going to shock an AFib patient, be sure he or she doesn't have sleep apnea. What about PVI, this ablation? You can tell me, well, we can just burn all the circuits and it'll all be fine, and who cares about sleep apnea? These data from Josephson lab suggests that, and these two bars, AFib-free survival in the vertical axis, PVI meaning ablation, OSA plus meaning they have sleep apnea, treated with CPAP. This is ablated patients with OSA, no CPAP. Treating the OSA patient with CPAP decreases the likelihood of recurrence of atrial fibrillation even after a pulmonary vein isolation. Now, when you look at the hazard ratios for recurrence of atrial fibrillation, what you find is that LAD, or left atrial diameter, is bigger the atrium, the more likely you are to recur. But if you have an ablation and sleep apnea and treat yourself with CPAP, you have a 0.7 hazard ratio, less than 1. If you have OSA and you're not treated, the hazard ratio becomes 2.15. So actually treating with CPAP gives you a threefold increase in risk of recurrence effectively after PVI. Now, very quickly, there's alternative treatments. These are data from Oklahoma, and a study in dogs where they made the dogs apneic for 3 minutes and pacing at 10 milliseconds below the atrial refractory period. So while the atrium is still not wanting to contract, you give a stimulus. And what they found was in the baseline, when they gave this premature beat or premature stimulus, the atrium didn't capture. It makes sense because the atrium is still refractory. In 0 of 11 dogs, no AFib and no capture. During apnea, however, atrial capture occurred in 10 of 11 dogs, and AFib was induced by that premature beat in 8 of the 11 dogs, and even one episode of spontaneous AFib occurred when they made the dogs apneic. Now here's a graph of the data. This is control. You see a couple of things. You see the EKG, you see the His bundle electrogram, and they measured the activity in the neurons of the ganglionated plexus, which Drew had talked about earlier, and this is blood pressure. After 15 seconds of apnea, they found that GP activity went down and EKG was fine. After a minute and a half of apnea, look what happens. You get bradycardia, very high levels of ganglionated plexus activity, and you get the development of atrial fibrillation. And this is the high activity of the ganglionated plexus, and here's the bradycardia that we saw earlier. Now, interestingly, what they did was they then ablated the ganglionated plexus, and atrial capture occurred in only 1 of 6 dogs, and none of them had AFib. So there's something about the ganglionated plexus of the right pulmonary artery that seems to act as a gateway for the autonomic triggers for atrial fibrillation. Now, we talked about Taft, and the reason I showed him to you was when he graduated from college, he was 6 feet tall, 320 pounds. 6 feet tall and 240 pounds. By the time he got to age 48, he was 320, always tired and sleepy, falling asleep at funerals, speeches. He was chief administrator of the Philippines, fell asleep during a typhoon, and his wife actually dealt with the whole situation. Taft had atrial fibrillation. Now, he was, as I said, chief administrator in the Philippines, also Secretary of War. He was also president of the U.S., then became professor of law at Yale, and then became Chief Justice of the U.S. Supreme Court. So here's Taft in this one apneic, drowsy, somnolent lifetime. He achieved more than most of us achieve in 10 lifetimes. So here's a therapeutic implication for you. What would have happened if we had actually treated Taft? So very quickly, I'll talk about sudden death, and here remind you of the misery that we saw earlier with the hypoxemia. This is a bad time. Very high levels, buckets of catecholamines in the bloodstream, hypoxemia, hypercapnia. This is like going up to Everest and coming back repeatedly during the night. Blood pressure, 240, 130, lots of stress. You think bad things will happen. And so we've been very interested in what happens at night in these apneic patients, and we did a study, and just about the time that we actually finished the analysis and submitted the manuscript, Reggie White passed away. Now, those of you who don't know Reggie White, he was 43 when he died. He was a Green Bay Packer. He died a few years after retiring, and he died suddenly, and he died unexpectedly, and he died in his sleep. Now, Reggie White had bad sleep apnea, and we don't know if the sleep apnea caused the sleep-related death, but what we do know is his wife is very convinced, because apparently he was being treated for apnea, and the week before he died, he stopped using his CPAP. And his wife is totally convinced. This is his wife, Sarah, and with Troy Aikman, John Madden, Warren Moon, Rayfield Wright. So she says he didn't wear his mask, and that's why he had the attack. Now, we don't know that for sure, but we have these data from the Olmsted County area where we were able to look at everybody who had a sudden death. And because so many people have had sleep studies in Rochester, if they move, we study them, we knew whether or not most of these people had sleep apnea or not. We knew they died. We knew they had sleep apnea. We also selected people who we knew the time of death. It was with some degree of accuracy that we could ascertain when they died. And what we found was, these are data culled from the literature. If you look at the general reports overall, what they tell you is 35% of sudden deaths occur in the morning, 6 to noon after waking from sleep. Only 16% will occur in the nighttime hours from midnight to 6 a.m. Now, if you look at people from our study who didn't have sleep apnea, they did exactly what the literature would predict. 20% died at night, 40% died in the early morning hours after waking from sleep. And if you look at people who had sleep apnea, died suddenly, died suddenly, and we knew the time of death, 46% actually died during the nighttime, and only 20% in that traditional high-risk period after waking from sleep. And so, you know, we've also seen, I won't share those data, that sleep apnea actually increases the overall risk of sudden death, whether during the nighttime or during the day. But from a therapeutic point of view, these are patients who have devices placed. They have ICDs. They're all at high risk for sudden death. And the device will tell you when it fires. You can go in and interrogate it, and it'll tell you, you know, I fired 3 times at 6 a.m. on this date, 5 a.m. on this date, and 2 p.m. on the other day. What they found was when they divided the groups into two, there's AHI less than 10, no apnea in these two, and these are people with apnea. This is from midnight to 6 a.m., and this is the other 18 hours of the day. Midnight to 6 a.m., the other 18 hours of the day. These people who had sleep apnea had excessive appropriate shocks from midnight to 6 a.m. So if you have an ICD and the ICD fires in a patient during the nighttime, look for sleep apnea in that patient. Very quickly, do I have 2 minutes more? Is that, do I do? 1.5, okay. So very quickly, I'm going to talk about another cardiorespiratory interaction which is not neural and its role in stroke. Now, when you look at people with sleep apnea, they have a high risk of stroke. Here's data from a New England Journal paper from Yale, and what they did was look at about, I think it was like 1,500 patients, and essentially showed that as your apnea got worse, at an AHI of greater than 36, you had a hazard ratio of 3.3 of getting a stroke. Now, when you think of sleep apnea, you've heard about sympathetics and all the other things. The other thing that happens is they have increased fibrinogen, very adhesive platelets, high blood viscosity, and maybe a high risk of DVT. And there are more and more data coming out now, maybe 4 papers showing the DVT risk in people without sleep apnea versus with sleep apnea. This is the with sleep apnea have a higher risk of not being free from DVT. So having sleep apnea also predisposes you to a deep vein thrombus. Why am I telling you all this? Because when we look at people with sleep apnea, I showed you the earlier slide of the Muller maneuver, struggling to breathe against an occluded airway. What we did was, these are data from Tom Konechny when he was in my lab, and he's actually, well, yeah. This is a PFO, and we were able to put a catheter across the PFO and a catheter here and do a Muller maneuver and look at the pressure gradient across the patent foramen ovale. So PFO occurs in 20% of people. It's just an embryologic defect. There's a hole from the left atrium to the right atrium, and blood can often pass across that, blood and maybe clots. So what we did was we looked at the pressure differential, and I hope you can see it from the back, but the left atrial pressure is shown in red and the right atrial in blue. And generally, at baseline, left atrial pressure is always a bit higher, so blood goes from the left to the right side of the heart. That's not a problem, okay? And then when you do the Muller maneuver, when you do this inspiration against an occluded airway, you get a whole different change in pressure, and this purple is the key. This is the difference between right and left atrial pressure. You see, suddenly, the purple goes up to a positive of 10. So at the beginning of the Muller maneuver, the onset, when you go, that's when you get a positive pressure in the right atrium that causes blood to flow from the right to the left. Why is this important? This is important because when you think about a clot, and I'll stop this. This is a clot in the, yeah, get that. So this is a clot, it's in the vein, and you're going to see it going up to the heart. Let's see, there we go. Yeah, you see it going up to the heart. And can you see it? Just cross the, did you guys see that? All right, so what it did was it came up and crossed over through this PFO from the right atrium to the left atrium, and we'll let it finish. It's going up the carotid artery into the brain, showing you what Ron showed you earlier, but in a more dramatic way. So that's what happens when you have a clot in a vein that goes up to the heart, crosses over to the left side, and goes up to the brain. Why is this relevant to sleep apnea? Because I showed you earlier the pressure changed from the right to the left, so that at the beginning of apnea you had that increased pressure. Now I'm going to show an echo image of the blood actually gushing across from the right to the left atrium during an apneic event. This happened because we had a patient on the table, we had the catheters in, we also had an echo probe in, and he fell asleep. And then he started snoring, and then he became apneic, and we said, oh my gosh, let's record this. So this is the let me just orient you. This is the right atrium. This is the left atrium. This is the PFO, patent foramen involved. There's a flap there. Now, when the blood gushes over from the right to the left, you will see a blue jet. This is Doppler, so you'll see the blood actually going across. And let's hope this sound. We'll probably need high sound here. Oh, golly. Now, this worked earlier. I'm so sorry. It worked earlier. It worked all the time. And I'm not sure why it won't work. Now, I'm really, really sorry. That's awful. It worked just before we started. Anyway, I guess we'll just have to skip that. You just have to take my word for the fact that that's going to happen. I'm so sorry. That's awful. Anyway, I apologize. It worked before we started the talk, and some snafu happened on the way. So you won't see it. So I'll end it by saying that we talked about sympathetic activation, bradycardia, atrial fibrillation, and sudden death, and I hope you got some messages about the cardiorespiratory interactions from a neuro perspective, but also from just a purely physical perspective, a non-neural hemodynamic perspective as well. So I'll take any questions if you have them. Thanks.